Hi, I'm here today with Dr. Amy Armstrong-Heimsoth, who is an assistant clinical professor in the Department of Occupational Therapy at Northern Arizona University on their Phoenix Biomedical campus. She also serves as an academic mentor for the Institute for Translational Research Education for the University of South Florida. Welcome.
Thank you.
I'm really happy and excited to have you here today to talk about the work you've been doing with children in foster care. And I'd like to really delve into sort of what you know about these kids and what kind of needs they present with and how occupational therapists can get involved.
Okay.
But let's just start with just a general question, background, how you got to where you are in this specialty area, et cetera.
Yeah, okay. So I've been a pediatric OT for 23 years now. And I originally went to USC and got my master's degree there. And I started teaching about 7 years ago, and I've been with NAU for the last 5. So one of the dilemmas I think that we face in a classroom setting for OTs is how to get good, rich, true pediatric experience into the classroom before students go out on field work, because a lot of students come to us with zero experience with children.
Right.
And we have to learn how to be therapeutic with kids. We have to learn how to be playful. We have to learn all the basics before we can really jump into a lot of clinical knowledge. And so right when I started with NAU, I happened to meet a man with an organization called Opportunity, Community, and Justice for Kids. And what they do is they provide a number of things, but one of their programs is that they provide volunteers that go into the group homes of kids in foster care to just give kids one-on-one attention, give kids things to do. Most of the kids who live in congregate care or group homes in foster care live in houses with a minimum of 5 beds, so 5 kids, and a maximum of 10 to 12 kids.
Wow.
At home with agency staff that are there with them, not a family. And so when I met Gary, Gary said, I really need more volunteers. We have all these kids who really need one-on-one attention. And I said, well, that's funny because I have some adults who need to learn how to be with kids, work with kids. And so Gary and I decided that we would try this out and see how it worked. They came and trained all of my students, my whole cohort, on the ins and outs of the system and handled all the paperwork and all those sorts of things in order for them to be able to be in the homes and be with the kids. And then on my end, I sort of assigned some different assignments to get them, get their feet wet with the clinical reasoning pieces, with planning interventions, with thinking about assessment tools and measurements. And it really just started there. I really only thought of this as opportunity for my students to get good hands-on experience. And Gary really only thought of it as, yay, more adults for our kids.
Right.
And since then, it has really expanded in a multitude of directions and research projects, and has really been an amazing partnership, I think, not only for OCJ kids, but our students and for the group home agencies too.
Right. So most of your specialty has been around the kids who are in the congregate foster care setting as opposed to in family care. Is that correct?
This is true.
Yeah.
So, and this is sort of a subset of the overall foster care community. In fact, a lot of people don't even really realize that we still have these group homes, these congregate care homes,
Right.
which, in some old circles used to be referred to as mini orphanages. and things of that nature. And a lot of people don't realize that we still have that, but reality is that we simply don't have enough homes for all the kids that need homes.
Right, right.
Here in the state of Arizona, that's true.
Yeah.
Yeah.
And I remember when you were first telling me about this, one of the things that I thought was so interesting was um, the characterization that these kids are whatever neurotypical or don't have any developmental issues, let alone what kind of traumatic experiences they've been exposed to. But then, as you've pointed out, they're also living in an environment. While I'm sure they do the best that they can, it is different than living with a family. And I'm interested in sort of what you've learned about what they get, what kind of screening, and how you kind of layered, uncovered some of those issues that they present with.
Yes, absolutely. So it's a good point to sort of step back and talk about the structure of the system. There are group homes which are specifically designed for kids with specific special needs. So for example, there are medically fragile group homes, and those would all be kids that have things like a ventilator or a trach or something that requires them to have nursing care fairly regularly.
Mm-hmm.
There's also group homes that are specifically designed for kids with behavioral issues, and they have more adult to child ratios. They're allowed to give certain kinds of medications. They're in a different sort of class or category. But there is also a large number, in fact, the biggest number of group homes is for kids that are typically developing kids. They just didn't have another placement.
Mm-hmm.
And those are the homes in which my students have been in. We have not been to any of the higher need, special needs types of homes. All of the kids that we have met and worked with and assessed have all been neurotypical according to the system. Yes.
But in some of the assignments that you give your students, as in this latest paper that you're working on, that you were identifying or able to identify that there were things that were atypical in their development. Is that correct?
That is correct. And when I first started seeing some of the assignments that I had required of the students come back in, I started doing a little bit more literature searching. One of the assignments that I gave the students is to administer a standardized assessment. They could pick anything that they wanted, any assessment that they thought would be interesting to do, or they thought would be harder, so they wanted to challenge themselves. They could pick any assessment that they wanted to. And then they were to turn the protocol sheet into me at the end of the semester. That's all de-identified. It only had our OT student name on it and an age and gender of the child. And when I started looking at what was being turned back into me and the rates of atypical scores, I was very curious about that. It was not what I expected. I expected some slight elevation in atypical scores, but not the amount that I was seeing. And I went and I looked at the literature, and the literature on this population is very problematic. First of all, there's no literature on just kids in congregate care. The literature that's reported is on system youth. So anyone who is in the foster care system is measured in that category. So Johnny, that grew up with grandma from 6 months to age 18, is considered system youth. And so is Allie, who's been in 10 group homes with 10 plus kids in the last 5 years. And we all kind of know that that's not, those two environments aren't equal. That shouldn't be the same grouping. We shouldn't be calling them the same group in terms of research. So that was the first thing that I saw. And then the second thing that I saw is that there was no developmental data. So developmental data would be a precursor to indications of disability and delay and potential diagnoses. And that wasn't there. There was no developmental data. There's very sort of gross numbers about kids in foster care having up to 60% of developmental disorders, or kids in care with special needs is up to 50%. Mm-hmm. But it was these very sort of not helpful numbers, essentially. So one of the papers that I've recently submitted for review takes the data from these kids, and it's all of the assessments that the students have used. So it's a mix. It's fine motor, gross motor, visual motor, cognition, any type of assessment. And we reported on 35 of the kids. Mm-hmm. And of those 35 kids, 29% of them scored outside the average range on any given assessment. So that's 83%.
So could have been any dimensions.
Across any of those dimensions. So 83% is a pretty staggering number.
Yes.
And so in doing that, I thought, well, you know, we need to keep going with this. We need to keep researching. We need to keep doing more. Another paper recently submitted is pulling out just the sensory data in and of itself. And what's been reported in the literature before is that 5 to 16% of all youth have sensory modulation challenges. And preliminary data from this paper that has just been submitted suggested that 90%, up to 90% of these kids may have sensory modulation challenges. So we're talking really staggering differences between these children and children who aren't system youth. And that impacts everything, right? That impacts all of our occupations.
Do you get any report from the staff that worked at the group homes, any feedback about issues that these kids present with? So that, like, how is the sensory differences, how are the sensory differences manifesting in these kids in the homes?
So typically that is reported as behaviors. Mm-hmm. And in fact, the system really, that's really the only service that the system itself provides, are behavior coaches and counseling services. Typically reported as behaviors or lack of attention. And that somewhat aligns with the research that is out there as well. When we look at kids that have IDEA or school-based services, all kids, only 6% of all typical youth have ED, emotional disturbance, as their primary eligibility category, whereas it's 26% of kids in the system. And I would imagine that if we could break that down to congregate care kids, it would be even higher than that number.
Right.
Yeah.
So is there a vision that you have in terms of how OT can be involved in addressing the needs, what kinds of maybe screenings that need to be done, even educating not just the staff, but probably the schools that these kids might be attending? I'm just wondering sort of, and how that kind of goes along with what AOTA might be recommending for OTs working in this field.
Yeah, so like I said, OT right now, our role with kids in care is really when the kids are referred either through school-based practice or when the children are placed with a foster family and they either seek out home-based care or outpatient-based care. The kids in the congregate care are not getting occupational therapy. I mean, just anecdotally, I have an agency I've worked a lot with, and I questioned them, how many of your kids receive OT services out of 300? And the answer was 0.
Right.
A lot of them have behavior coaches, however. So one of the things that is required of the system is that anytime a child is placed in care, within 7 days, they have to have a primary care physician visit. That is either in a physician's office, or for the teens, a lot of times they will actually come to the group home and do that initial visit. But that is an absolute state mandate within 7 days. And in theory, they are doing early screening for development at that visit. In theory, that is supposed to be done. Of course, this is a little problematic, and it doesn't seem to be that this is always followed through upon, just based on evidence that I've seen in practice. What I think would be highly beneficial is if occupational therapy could be in those primary care settings doing developmental evaluations when a child comes in. And potentially, if they can only do screenings during that first visit and then follow up with an evaluation at the home, I think that would be ideal. It's just obvious that a lot of these kids are being missed with the numbers that we were talking about just a minute ago that we've seen from the kids that we've been exposed to. The kids are getting missed, and OT needs to be in that primary care setting to be identifying kids quicker, or to be getting assistance to them through the system itself, rather than referring out. You know, for example, being in school-based practice and potentially working with the kids. First of all, you have a number of delays in school-based practice, just inherent in the paperwork process of school-based practice.
Right.
Second of all, most of the kids that are in these group home settings get moved quite often. They have high placement instability. They have multiple settings. And every time they do that, they're also transitioning school as well, which is yet another delay in their getting services or a therapist getting to know them well enough, and those sorts of things. So I truly believe that we need to be a service that the system itself provides through that primary care portal, I think, is where we need to be.
Is that something that occur on a state level, or is that more of a national level? Where does the change have to begin?
So I think the change has to begin at the state level. And I think we're probably really talking about a grant-based program in the beginning to show outcomes, to demonstrate the need, to demonstrate the change that OT can make in that fashion. I think that as well, we need to seriously consider becoming qualified mental health professionals in each of our states. That's a state level decision as well. That would allow us not just to work with kids in the system, but also it would allow us to work with kids who have aged out of the system, who is a whole other population that I've been researching and working with. You know, when you have kids who have who are in the system that have all these statistics that are just staggering, like they are 2 times more likely to have PTSD than a vet that's returned from a war.
Wow.
They are 4 times more likely to try to commit suicide, 5 times more likely to get a drug dependence diagnosis. Down the road, when they age out of the system, those outcomes aren't good. And when we talk about transitioning out and working on independent living skills, I mean, where else does OT need to be? We need to be doing independent living skills with these young adults who have aged out and have very poor outcomes as of right now. Very poor outcomes.
Yeah, that's huge. That's really
Yeah.
huge. Given that probably statewide change takes time, do you plan or have you had any experience with educating the staff that you have been involved with through your students? So when you get these results, whether they're sensory issues, motor issues, both, is there a mechanism through which you, as the sort of the primary OT, but maybe even channels through the students that you work with to have any impact on those settings that you have been exposed to?
Yes, so all of the students are required to develop a home program, a list of suggestions on things that they can do in the home to impact development in a positive way. And they are to, just like as in practice, to align with the issues that they have seen or the issues that the staff reports. So those are given to the group home staff. They're also given to the community agency that assigns all the volunteers. That community agency has also started establishing supports to be brought in. We've developed some kits that help with developmental milestones that volunteers can check out and take with them. And we're looking at next expanding into doing some trainings with group home staff. They have quarterly trainings that they're required to do, and we are looking at embedding some of what we know about development and how we can improve resilience and development in kids into those training sessions as well.
Yeah, that really feels like it's also would be when you start to initiate certainly the education pieces, it would be really ripe for some kind of a study, both in terms of how the staff feel like their knowledge has improved, how they feel like their competency in a relation to the kids that are living there, how they feel regarding their own ability to manage the kids, and and actually even doing a needs assessment, I guess, would be your first step to see what are they feeling like they are missing in their background to be able to best support the kids.
Yeah, it's interesting that you say that, because that's actually, we're going to do that for the first time in the fall at this level. So the students go out through 3 different courses over the course of a year. So they have a year-long engagement with the same home. Mm-hmm. And in the fall, the assignment is going to be to do a needs assessment with the staff in order to figure out what developmental supports would be most needed, would be most welcomed, and would be utilized the most by the staff in the various homes. So.
Yeah, and I don't know that much about needs assessments, but I would imagine that part of that is really investigating where they feel like they have the biggest challenge. I mean, like when parents come in on an individual basis in any, many therapy settings, it's like, well, what are your priorities? What are your concerns? What do you feel like you need help with in terms of making home life, better for you and your child? And it's really like, for that group home, it feels like, what are the behavior management challenges? What are the physical challenges? What are the emotional challenges that the kids face that you feel, or they, putting into their words, what they feel is the biggest obstacle to them, running the day-to-day life of that particular home. And I also wonder if it's different depending on what their shift is, or, are they in the morning shift or the afternoon? When are the biggest challenges? I mean, because I imagine it, right? They don't have people who are there 24/7, right? I mean,
there are very rare homes where the staff is living. And it's very rare, right. But no, they do shifts like any other place would that requires round the clock care. So
yeah, So it just was curious because, I mean, as a parent, I'm sure the witching hours that you've had when your kids were younger. Is
Yeah,
that the same in a group home, or is it like, and getting everybody ready in the morning can be, a huge challenge. Just
yeah.
I'm thinking doing homework with all of the different kids. How many kids are assigned to each staff person? What is that ratio?
So some houses are 5 to 1. So they have to have one staff for every 5 kids. And then some houses are 8 to 10 to 1,
Wow.
or 10 to 2. Those are kind of the common. And then they group the homes. So there are some homes that are dedicated to siblings. Um, there are some homes that are birth to 10-ish, 12-ish, and then there's the teen homes, the 12 to 18. And then there's also like teen mom homes. So for the teens that are pregnant or just had a child, and potentially the baby is there with them. Um, so that's typically how they break it up.
So if they are broken up by having kids of similar age, do then they just if they don't get placed any other location or setting, do they all just grow up together then within that group home?
That is the hope and the design of a sibling group home. Does it always work out that way? Not always. Sometimes actually siblings don't get along as well as people that are non-siblings. So sometimes they are broken up because of that. The system tries its best to keep siblings together in the state of Arizona.
Yeah.
Yeah.
So in summary, let's say, if you have your wish list of what you hope to see in the future, for these kids, I know you've mentioned some of it, but maybe if you can just sort of put it all together in sort of this nice, ideal setting, could you just share that with us?
Yeah, so I would definitely hope that we could be a part of the healthcare home for kids, be a part of the primary care office, also be able to do home visits in the group homes, because environment is such a big factor in their development and their growth. So ideally, I would love to see us that as a system support, particularly for kids with more than 3 placements. Research shows that the higher the placement, the worse the outcome for kids. So the kids with placement and stability should really be our focus first. I would love to see that be just a standard of care, that they didn't have to jump through hoops or get qualified, but once they had 3 placements, they just got OT.
Right.
Would love to see that. And I would also love to see us in more transition programs for when kids age out. We need to be in those independent living skills programs too. We would bring a much different lens to those programs that's currently been provided.
Yeah. And if you were an OT now, whether, early in your practice or mid practice stage, and this was an area that you were interested in getting more involved with, is there a particular agency within each state that one would go to try to investigate and explore getting involved, or would AOTA have any resources towards that?
I don't know that AOTA has a list for all the organizations. I think um, Child Information Child Information Gateway. I'm tripping over that. It's a national database that has information about all of the systems and all of the contacts. Health Information Gateway. I cannot think of what it's called right now. Or also whatever the state organization is. Like in Arizona, it's called the Department of Child Safety.
Right. So that sounds like that might be sort of, I'm sure each state has an agency such as that to.
Yes, absolutely. And then typically they have a list of all the resources and supports that are available to the agency.
Mhm.
And they usually have them categorized under all the different types of supports that they can give. So that would be a really good place to start too, as well.
Well, there's a lot of work to be done. I had no idea. And I'm really, I mean, you know, the evidence that you're presenting is so compelling about the need and the lack of services and resources for this population. It just pulls at my heartstrings. So I hope that there people who are listening to this will also feel the same. And I'm sure, you know, they can get in touch with you at NAU if you want to help sort of direct them in terms of their own state and how to navigate through the system as well.
Yeah, I would absolutely love to help. Anybody can feel free to reach out to me. My email is very easy. It's just amy.armstrong@nau.edu.
Great.
That's probably the easiest way to get me. But yeah, I would love more OTs who feel passionate about helping these kids, like my research assistant team and I do.
Yeah,
Fabulous.
absolutely. And we'll look for your publications and maybe presentations at AOTA. So
Yes.
thank you for taking the time with us today. We really appreciate it.
Thank you very much.